Hello, everyone. Welcome to this virtual tumor board. It's a pleasure to bring together international faculty to discuss these cases. Before we get started, we'll just do a round of introductions. I'm Dr. Benjamin Levy, and I'm Associate Professor at Johns Hopkins School of Medicine, a thoracic medical oncologist. I am joined here today by, again, a fabulous international group of physician scientists. We'll start with Dr. Sanjeev Bala. You want to introduce yourself, Dr. Bala?
Yes, hello everyone. My name is Sanjeev Bala, and I run the cardiothoracic radiology division here at the Mallinckrodt Institute of Radiology at WashU in St. Louis. Nice to be here.
My name is Wally Curran. I'm the executive director of Winship Cancer Institute here at Emory University and chair of the Department of Radiation Oncology.
Hi, Dr. Levy. I'm glad to be here. I'm a professor of surgery and a thoracic surgeon at the Washington University in St. Louis.
So I'm Dr. Mark Socinski. I'm a thoracic medical oncologist and the executive medical director at the Advent Health Cancer Institute in Orlando, Florida.
Great. So let's get started. This next case is a 35-year-old male diagnosed with metastatic lung cancer to the brain and bone. The patient's tumor harbors an EGFR mutation, treated with osimertinib, then chemotherapy and immunotherapy, now with progression. So we're going to look at some different lines of therapy. The EGFR is an exon 19, and the tumor does not harbor, is a PD-L1 0. So this patient initially presented with shortness of breath and was found to have a pulmonary embolus. At the time of presentation, the patient was pretty debilitated and had an ECOG-2, and I think that was mostly related to the symptoms that he was having over the prior week prior to being evaluated for his pulmonary embolism. I think we'll find that he's much more fit than that. The past medical history, really none. He's a young guy, no medications. He's a never smoker, no alcohol or drug use. His family history is negative for any lung cancer or any other cancer for that matter. So because the patient had presented with some shortness of breath, I've already told you that there was a PE, but we found other findings on the CAT scan. And we're also, again, going to show you some of the full staging with a brain MRI. So Dr. Bala, do you want to walk us through the CAT scan and the brain MRI?
Sure. So if we look at the lung windows, which are on the top row, we can see that there's a dominant spiculated lesion in the right upper lobe. But in addition, there are all these tiny nodules throughout the lungs bilaterally, which are in keeping with diffuse metastases throughout the lungs. I would just draw your attention that if you notice, some of these nodules touch the pleura, and that is a really good finding for metastases. So when you're confronted with multiple nodules, something to look for. The only thing that can sometimes mimic that is fungal infection, but these nodules are bigger than what we'd expect to see for a fungal infection. On the row below, again, we see a post-contrast MR, which shows that there's enhancing lesions bilaterally with areas of vasogenic edema, but there's no midline shift. It looks like the box is still within the midline.
Great. So as Dr. Bala mentioned, the CT shows bilateral lung tumors. The brain MRI reveals multiple brain mets. The PET scan, which we didn't review, does confirm these bilateral lung lesions and bony lesions as well. The patient has a biopsy of one of the lung lesions. I assume it's in the right lung. That seemed to be the most amenable. And the pathology is consistent with a adenocarcinoma of the lung. The PD-L1 is negative, and the patient has an EGFR exon 19 deletion. So, patient with advanced lung cancer, EGFR positive, and this case has some interesting nuances to it on how actually the patient was treated. But Dr. Socinski and Dr. Curran, again, this is sort of a battle between the medical oncologist and radiation oncologist. You've got these brain mets, you've got lung bilateral disease, you have an EGFR exon 19, perhaps turning to Dr. Socinski first, how you would manage this patient if they were in your office.
The exon 19 is the most sensitive mutation we have with regard to EGFR mutations. Osimertinib is highly active. It has great brain penetration. I think in distinction to the RET case, we have substantially more data here on the treatment of CNS. I'm blanking on how symptomatic this patient was from the CNS point of view. I guess I was assuming that they were not very
Not
symptomatic.
asymptomatic, yeah.
Yeah, I think this is a perfect situation given the breadth of data that we have on osimertinib from the FLORA trial, the previous AURA trials looking at CNS activity, of starting with systemic therapy that would treat both the advanced lung disease as well as the CNS disease.
Okay. Dr. Curran, your thoughts on this case as a radiation oncologist for the
Yeah,
brain?
no, I would agree with that approach. And as Mark said, there's better data. It's a lot of disease in the brain, I'm guessing, so it's going to need to be watched. And the risk of response and then progression is there. So I'm guessing at some point this patient will get cranial radiation of some type, but getting a long run out of the OC, I think would be great.
Okay. So we don't know in this case the timing of the mutation versus the delivery of the radiation. It may have been that the genotype or the EGFR mutation wasn't discovered, and the decision was to give whole brain to this patient. And then the EGFR was discovered afterward. The patient got osimertinib. I think I agree with both of you that if you knew the EGFR mutation up front, that osimertinib would probably be the way to go. And even if you didn't, maybe, I don't know, watching these without giving whole brain until the genotype came back.
Well, Dr. Levy, can I ask Dr. Curran a question? How widespread is the appreciation of these driver populations in say a general radiation oncology practice in the U.S.?
Slowly emerging would be my guess, at best. Yeah. So again, some of these, for example, in the case of RET fusion, are probably sub-studies of published data, or very minor things. The OC data is out there a little more.
Yeah.
But yes, it's not out as much as you and I would like it to be.
Yeah. Okay.
So this patient does get whole brain, and then gets about a year of actually more than a year. Gets around 18 months, which is kind of right in line with the FLORA data, January 2019 to July 2020. But then in July 2020 has a PET and also has a brain MRI, both. And Dr. Bala, maybe you could walk us through the PET as well as the brain MRI.
Great. Yeah. So in the upper row, you can see images from the FDG PET that shows that there's been progression of disease. There's this increased uptake in the hilum, and there's now areas of lobar collapse and some lymphadenopathy in the hilar region. And on the brain MR, an arrow is demarcating some areas of leptomeningeal spread on the post-contrast images in the regions of kind of the basilar cistern. So there's definitely been some progression on both the PET with this new leptomeningeal disease on the brain MR.
Just one question, are there discrete nodular lesions in the brain as well, or is it mainly confined to leptomeningeal disease?
It's mainly confined to leptomeningeal.
And is it diffuse or focal, somewhere in between?
It looks like it's somewhere in between. It's a little bit more focal in the posterior circulation region, but it's a little bit more than just one nodular area. But it's more on the focal side.
Okay, thank you.
I'll be curious, Dr. Curran, just to get your take on those questions. I'd like to learn about your decision making based on the answers to those questions. So, the MRI, as Dr. Bala mentioned, showed leptomeningeal disease, and now we've got a PET scan at the same, basically showing progression of disease in the right hilum. So, tough case. We see this a lot. Young guy, EGFR positive, got whole brain radiation, got about 18 months of osimertinib, and now has disease progression in the chest with some leptomeningeal disease. And I will tell you that, I think all bets are off here on how to best manage these patients. I'm not real clear on the best strategy, even when I do see patients like this. So maybe we can tackle the leptomeningeal disease first, and given that's probably the most pressing here. And I really didn't go through clinical exam or cranial nerve issues. I don't know those, but Dr. Curran, maybe just walk us through kind of how you approach this and what you would do in this case.
Yeah, well, leptomeningeal carcinomatosis is as tough a problem in oncology as we have. The options for intrathecal therapy are pretty limited, particularly for lung cancer. There are now animal studies of immunotherapy going on, being given intrathecally at several centers, including MD Anderson, but I'm not aware of any clinical studies going on. Intrathecal therapy in general does not really distribute very well through the cerebrospinal fluid in the brain. It's probably effective for disease in the spine. Whole brain radiation is palliative. There are times where people get remarkable responses. There are times where people have focal cranioneuropathies, where focal radiation to a given nerve root or facial nerve or other nerves can be effective in a durable palliative way. This case is very tough because the patient's already seen whole brain. Looks like the patient had a nice response to the OC and whole brain in terms of their metastatic disease. But I sure don't have a great idea on how to treat this carcinomatosis.
Okay. Dr. Socinski, your thoughts on this, and what systemic options would you potentially consider given the patient's already had radiation, develops progression of meningeal disease and disease progression in the chest? Young, fit patient?
Yeah, the first thing I might do is double the dose of osimertinib and see if you could get some mileage out of that. We do know from the Bloom study that looked at twice the standard dose of osimertinib, 160 milligrams versus what we typically use as 80 milligrams, that there was some activity. I'm not saying it was impressive activity. I'm just saying there was some activity there. I agree with Dr. Curran. This is one of the most difficult situations we face, not only for our radiation oncologist, but for our medical oncologist here. I have given systemic chemotherapy, but I don't feel good about it. I don't know that we know that it provides any degree of benefit. These are very difficult cases, and I think the first thing I would do would be to try to double the dose in a short interval follow-up of both clinical symptomatology, neurologic function, as well as imaging, to see if you were getting any advantage there. You know, there was some data in years past of using pulse doses of some of the first generation drugs that did clearly show some activity. So this concept of looking at the brain as a kind of a pharmacologic or pharmacokinetic sanctuary, if you will, should remind us that, pushing the doses into the CNS, you may get some mileage out of them. Although, again, there's not a ton of data in that setting.
Yeah, really nice overview. I think that it's one of the more challenging cases we see. And especially in these younger patients, oftentimes the EGFR biology is more aggressive. And I would agree with you. I think that I would have all considerations here. Doubling the dose of OC could be one option. I'm going to tell you how this patient was treated, and the plot thickens. So the patient, I guess the decision was to use a regimen, Dr. Socinski, you're very familiar with. And I guess the thought was this 4-drug Empower 150 regimen. We do have some data that patients who have disease progression on a TKI have a meaningful benefit with this regimen. I don't think any of those patients in the study had leptomeningeal disease, but you can certainly educate me if that's the case.
No, they did not.
Yeah, and I think that maybe the thought is that there is some ongoing data that immunotherapy may cross the blood-brain barrier. We have some data, at least in the PD-L1 highs, that immunotherapy may be able to treat leptomeningeal disease. And so the decision was to give the 4-drug combo to tackle the disease below the neck and in the brain. And so the patient actually did well. The CT scan after maintenance atezo-bev for 6 cycles at least controlled the disease in the brain. So after 6 cycles, the brain MRI is actually okay. The leptomeningeal disease is either, I don't know the details, but either stable or regressing, but now the patient has progression below the neck, highlighting everything that you mentioned, the pharmacokinetic sanctuary, whether the biology is different above or below the neck. The question is, what's next for this patient? Again, who's been on whole brain radiation, osimertinib for 18 months, has disease progression both in the lung with leptomeningeal disease, gets the Empower 150 regimen for 6 cycles, and now has control of disease in the brain, but has progression of the disease in lung.
Okay. And so I assume, Dr. Levy, that at the time the switch was made to the Empower 150 regimen, the osimertinib was discontinued?
I would hope so.
Yeah,
that's a good point.
I just want to make sure, because one of my initial thoughts, again, would be, going back to osimertinib in this setting. Because the patient's been 6 months, 6 cycles, 18 weeks, without this. We know that the native mutation doesn't go away. So maybe they're progressing in the lung mainly because they don't have inhibition of EGFR at this point. So that's probably the first thing that I would do. I don't know if I would do it I'd be comfortable keeping the bevacizumab going. I'm not sure I would be comfortable keeping the atezolizumab going with the TKI. There's been some.
Can you just explain what that is? What is your rationale for using both of those together?
The TKI, what we've seen with the use of TKIs following exposure to immunotherapy is a heightened risk of immune-related adverse events, particularly pneumonitis and hepatitis and these sorts of things. So I think I have no hesitation using it with the anti-VEGF agents. But I would do it with either ramucirumab or bevacizumab in this setting. We have precedent for that. But the immunotherapy would make me a little make me a little uncomfortable, and you'd have to be very, very vigilant for pulmonary symptoms in someone like this if you're going to go back to the osimertinib.
Yeah, and just I don't think there's any right answer here. I think we're reaching, and this is where medicine becomes an art and not a science. I don't think we have any data really how to manage leptomeningeal disease all that well, and certainly not how to manage it as a third line in an EGFR positive patient.
The only other additional comment that I would make, Ben, would be looking for another resistance mechanism that might give you a clue, MET amplification, another bypass track, something like that, where you might, So
your comment is right on cue. So let's go to the second scenario here. Let's go to the second scenario. So let's say that this patient does get a biopsy. Let's say the biopsy is done after the immunotherapy. And let's say that there is high MET amplification, which we see as a mechanism of resistance to TKI. And remember, the patient came off the TKI and was on immunotherapy. What would you do with this information as a third line in the same scenario? Tough question. With high MET amplification, would you reach for a MET-directed therapy?
I would consider it, yes. I would either on or off a trial. We do have some approved MET drugs out there right now, so I would strongly consider that. If I guess it depends on, when you say high amplification, just how high was it?
Yeah.
The higher the better, so to speak, so that you could be confident that it really is a driver. And if you target it, you would see some therapeutic benefit from it.
Yeah. Would you consider, if the MET amplification or MET by IHC was positive on the first progression with leptomeningeal disease, would you consider giving it then before the chemoimmunotherapy regimen?
I would. I'm swayed by what happened in this case. I think the textbook answer is Empower 150 is the right answer here. Would I have done that? I mean, I think I would consider it, depending upon how much MET amplification, what you mean by high amplification.
Yeah.
If you had borderline copy numbers, 4, 5, 6 or something like that, I wouldn't be enthusiastic about it. If it was really, say 20 plus copies, that would make me more enthusiastic about it.
Got it. Still trying to find that right biomarker for MET.
Right.
It really is, we're in the beginning stages of this, chapter 1. Well, thanks for everyone's participation in this very complicated patient and really highlighting some of the real therapeutic challenges that we have in this mutation, especially with somebody with aggressive tumor biology.